Right now, as you are listening to this, your body is walking a microscopic, high-wire tightrope.
Yeah, a really, really precarious one.
Exactly. I mean, if the pH of your blood drops from its perfect physiological midpoint, which is about 7.4, down to just 6.8, the fundamental building blocks of your body physically break.
They just fall apart. Cellular enzymes start to misfold and crumple.
Right. They lose their shape, they abandon their functions, and then the electrical conduction system in your heart destabilizes. And very quickly, that leads to death.
It's terrifying when you think about it. The survivable window is incredibly narrow, basically just 7.35 to 7.45.
And that narrow window is under constant assault, right?
Oh, constant. Just through the basic act of cellular respiration, living, eating, moving, we generate massive amounts of acid every single day.
Which means we are all just one physiological misstep away from our own blood becoming a toxic swamp.
Pretty much, yeah.
So for you listening today, whether you're a nursing student prepping for an ICU shift, a clinician brushing up on your labs, or just someone fascinated by how you're surviving right this second, we are taking a deep dive into acid-base balance.
It's a huge topic.
It really is. So our mission today is we're going to decode arterial blood gases using the famous Rome shortcut.
Yes.
We'll explore the terrifying historical crisis that birthed the modern ICU and dismantle some major textbook misconceptions about how your body actually defends its pH.
I love that we're starting with the defenses, because
Yeah.
to even approach a blood gas readout, we have to establish how the body defends that tightrope balance before medical intervention even enters the picture.
Right. And the body utilizes 3 distinct layers of defense.
Yeah, and the critical variable separating them isn't location, it's actually speed.
Speed. Okay, let's look at the timeline. The first layer is essentially instantaneous, right? Operating in seconds.
Exactly. These are the chemical buffers circulating in the blood.
So if we think of hydrogen ions as like the microscopic sparks of acidity, buffers act like fire blankets.
That's a great analogy. They chemically bind to excess hydrogen or conversely to basic hydroxide ions.
Right, instantly neutralizing them so the overall pH doesn't wildly swing.
Then the second line of defense steps in over a matter of minutes. And this one is driven by the respiratory system.
Okay, the lungs.
Yeah. The medulla in your brainstem acts as a chemical sentinel. It's constantly monitoring the carbon dioxide levels in your cerebrospinal fluid.
Because carbon dioxide in the body is functionally synonymous with acid.
Exactly. When CO2 mixes with water in the blood, it forms carbonic acid.
So the lungs control the acid by controlling the CO2. I mean, if the medulla senses too much acid, it triggers an increase in the depth and rate of breathing to literally blow the carbon dioxide out of the system.
Right.
I always think of this when someone is having a severe panic attack.
Yeah.
They hyperventilate, blowing off so much CO2 so rapidly that they can induce respiratory alkalosis in under 10 minutes.
Right. Their blood becomes too basic simply because their lungs are dumping acid faster than the body is producing it.
Wow. Which leaves the final layer of defense to clean up the long-term mess. The kidneys.
The kidneys. This is the slow, methodical defense. They physically excrete or reabsorb hydrogen ions into the urine.
And they manufacture or excrete bicarbonate, which is our primary metabolic base, right?
Yep. But they require 6 to 12 hours just to initiate this process.
Oh, wow.
Yeah, and achieving their maximal buffering effect takes 3 to 5 days. In some chronic conditions, it can take up to 2 weeks.
2 weeks. That is slow. But hey, I do want to pause on those chemical buffers you mentioned in the first layer.
Okay, sure.
Because anyone who has opened a nursing or physiology textbook will recognize bicarbonate as the absolute star of the show.
Oh, 100%. It's paired with carbonic acid in literally every diagram.
Right, so the natural assumption is that bicarbonate is doing the heavy lifting in our circulating blood.
And that assumption is actually one of the most pervasive blind spots in early clinical education.
Wait, really?
Yeah, I mean, while bicarbonate is crucial, the primary buffer in whole blood is surprisingly hemoglobin.
Hemoglobin, the oxygen transport molecule.
The very same. Gram for gram, hemoglobin performs more acid-base buffering work in your whole blood than bicarbonate, plasma proteins, and phosphate combined.
That is wild.
It manages roughly 60% of your daily acid load.
Okay, that fundamentally changes how you look at a complete blood count.
Yeah.
I mean, anemia isn't just an oxygen delivery problem, it's a buffering vulnerability.
Exactly.
How does an oxygen carrier manage that much acid, though?
Well, it comes down to molecular architecture. Hemoglobin contains a high concentration of specific amino acid side chains, particularly histidine residues.
Okay, histidine residues.
Yeah. The structural geometry of these histidine residues makes them highly effective at binding and releasing free hydrogen ions based on the surrounding pH.
So hemoglobin is just constantly soaking up acid in the peripheral tissues and then releasing it in the lungs to be exhaled.
Exactly. It's the frontline bouncer for the blood.
That's amazing.
Yeah.
But knowing how the body does this internally is very different from a doctor being able to measure it externally at the bedside.
Right, right. I mean, the underlying chemistry for all of this, the Henderson-Hasselbalch equation, that was established way back in the 1910s.
But having an equation on a chalkboard doesn't save a suffocating patient.
No, it doesn't. The translation from abstract chemistry to bedside clinical application required a catalyst. And that catalyst was a devastating public health crisis.
Which was what exactly?
Well, in the summer of 1952, the Blegdam Hospitalet in Copenhagen faced just an overwhelming polio epidemic.
Oh, right. Polio attacks the motor neurons.
Yeah. And in the most severe bulbar cases, it paralyzed the patient's diaphragms and intercostal muscles.
So they were completely unable to pull air into their lungs.
None at all. The virus wasn't destroying their lung tissue, it was destroying the mechanical pump.
Wow.
Because they couldn't exhale, carbon dioxide accumulated in their blood far faster than hemoglobin could buffer it.
So they were experiencing catastrophic respiratory acidosis.
Exactly, with mortality rates for the sickest patients hovering between 80 and 90%.
And the negative pressure ventilators, the iron lungs, they couldn't handle the sheer volume of patients.
No, they were totally overwhelmed. And iron lungs were useless for managing airway secretions in patients whose throats were also paralyzed.
Right. So the traditional technology failed.
Completely. But an anesthesiologist named Bjorn Ibsen realized the only way to save them was to completely bypass the upper airway.
Okay, what did he do?
He proposed a really radical intervention, performing tracheostomies and manually forcing air into the lungs using a rubber bag. Basically, positive pressure ventilation.
The logistics of that are staggering, though. I mean, you have a ward full of paralyzed patients who need to breathe 15 to 20 times a minute around the clock.
Yeah.
You can't just hook them up to a modern mechanical ventilator because those didn't exist yet.
Yeah.
Who is physically squeezing those rubber bags for weeks on end?
So the hospital organized a massive conscription of roughly 1,500 medical and dental students.
1,500 students.
Yes. They worked in relentless 8-hour shifts, just sitting at the bedside, squeezing the bags by hand, 24 hours a day.
That human mobilization essentially created the very first intensive care unit.
It really did. Mortality dropped to like 20 or 25%. But the manual bagging created a new physiological problem.
Oh, right, because if a student squeezes the bag too aggressively, they blow off too much CO2 and the patient becomes alkalotic.
Exactly. And if they get tired and squeeze too slowly, the CO2 builds up and the patient becomes acidotic.
So the clinical teams were flying blind. They desperately needed a way to measure the acidity of the blood in real time to adjust how they were bagging the patients.
Yes, and this urgent need pushed a Danish biochemist named Paul Astrup to invent one of the world's first practical bedside blood gas analyzers.
So every ABG machine sitting in a modern hospital today traces its lineage directly back to those medical students manually keeping polio patients alive in Copenhagen.
It really does. It's an incredible legacy.
But Astrup's machine just gave clinicians the raw data. I mean, staring at a slip of paper showing a pH of 7.2 while a patient is coding, that isn't enough.
No, you need to act. Clinicians needed a framework to translate that math into an immediate diagnosis.
And that necessity birthed the Boston approach and the classic bedside heuristic known as ROAM.
Yes, ROAM. To utilize ROAM, you first have to memorize the 3 unshakable reference ranges.
Okay, let's lay them out. First is pH.
Right, pH is 7.35 to 7.45. Second is the respiratory variable PaxO2, that's 35 to 45 millimeters of mercury.
Okay, 35 to 45. And finally, the metabolic variable bicarbonate,
which is 22 to 26 milliequivalents per liter.
Which brings us to the acronym itself. ROAM stands for respiratory equals opposite, metabolic equals equal.
It is fundamentally a pattern recognition tool. So if you look at the lab results and the pH has dropped into acidosis, you check the CO2.
Right. And if the CO2 has gone up, meaning pH and CO2 moved in opposite directions, the primary issue is respiratory acidosis.
The logic holds perfectly too, because CO2 acts as an acid. If the lungs fail to exhale it, retaining that acid naturally pushes the pH down, opposite directions.
Makes total sense. Conversely, if the pH is low, and you check the bicarbonate, and it is also low, they moved in the same direction. They are equal.
Exactly.
That tells you the primary issue is metabolic acidosis. The body lost its base buffer, dragging the pH down with it.
It provides instant directionality during a crisis.
I would think of Rome like a compass. I mean, it tells you if you are heading north toward a respiratory issue or south toward a metabolic issue. But a compass doesn't tell you what city you're standing in.
Right. A respiratory acidosis pattern tells you the patient isn't moving enough air, but it doesn't distinguish between, say, a severe COPD exacerbation and an opioid overdose that suppressed the brainstem.
So Rome spots the pattern, but the clinician still has to diagnose the underlying cause.
And part of diagnosing that full clinical picture is determining whether the body's other physiological systems are attempting a rescue. We call this compensation.
Right,
Observing compensation in real time illustrates exactly why that speed difference between the lungs and the kidneys matters so much.
Let's apply this to a fast compensation scenario. Let's say a 24-year-old arrives in the emergency department in diabetic ketoacidosis, or DKA.
Okay, classic case.
Their body, unable to use glucose, has started breaking down fat, which floods the bloodstream with keto acids. We draw an ABG, and the pH is a disastrous 7.15.
Ouch.
And the bicarbonate has crashed down to 8.
Okay, so following Rome, both pH and bicarbonate are low. They moved in the same direction. Metabolic equals equal.
So this is a primary metabolic acidosis.
Exactly. The keto acids have overwhelmed and consumed the circulating bicarbonate.
The metabolic defense is broken. So this is where the lungs, that rapid second layer of defense, initiate the rescue.
Right. The medulla detects the plummeting pH and immediately triggers small respirations. That deep, rapid, labored breathing.
The patient is literally trying to exhale the acid load.
Yes. And when we look at the CO2 on the blood gas, it has dropped from a normal 40 down to, say, 20. The lungs are compensating rapidly.
Okay, now contrast that acute crisis with a slow compensation scenario. A 68-year-old patient with severe, long-standing COPD.
Right. Their lungs have been mechanically compromised for years.
Let's say their ABG reveals a pH of 7.33, a mass of CO2 of 68, and a bicarbonate of 34.
So running the Rome compass on that, pH is slightly low, CO2 is wildly high. Opposite directions, we're looking at a primary respiratory acidosis.
But their fast defense, the lungs, is the very thing that's broken. They can't just breathe faster to fix it.
Right. Therefore, the metabolic system has to shoulder the burden. Over months and years, the kidneys have steadily retained bicarbonate to buffer that chronically retained CO2.
Ah, so that is why their bicarbonate level is elevated to 34.
Exactly. Which beautifully explains why their pH is 7.33. It's mildly acidotic, but for a CO2 of 68, you'd expect a much more dangerous pH.
The kidneys are blunting the impact. But this raises a trap that catches a lot of learners, right? If the kidneys or lungs are compensating perfectly, does the pH ever just return to a perfect 7.40?
Almost never. While the primary disorder persists, physiological compensation will blunt the pH shift, but it will not completely normalize it.
Okay, so a perfectly normal pH on a blood gas isn't always a sigh of relief.
Definitely not. A perfectly normal pH paired with highly abnormal CO2 and bicarbonate is the illusion of normalcy.
The illusion of normalcy.
Yeah, it strongly suggests a mixed acid-base disorder. You aren't looking at one problem being elegantly solved. You are looking at two independent disease processes occurring simultaneously.
Just artificially canceling each other out on the pH scale.
Exactly. Like, for instance, a patient with chronic COPD who also develops acute DKA.
Wow, okay. So relying purely on the Rome pattern without respecting the underlying physiology is dangerous.
It leads to what we call the fix-the-number fallacy.
Right. If we look back at the history of treating that DKA patient we talked about, for decades, doctors looked at the severely low bicarbonate on the lab report and thought, well, they need base.
Right. Let's just hang a bag of IV sodium bicarbonate and neutralize the acid.
It seems intuitively correct to treat an acid with a base. If they are full of acid, why wouldn't you just give them a base to neutralize it?
Because clinical outcomes revealed it was often actively harming patients.
And the reason why really reveals the complexity of human biology. The blood-brain barrier is highly permeable to carbon dioxide, but relatively impermeable to bicarbonate.
Yeah. So when you push rapid IV bicarbonate into a patient's bloodstream, it immediately reacts with the circulating acid, right? It neutralizes it, but it generates a massive amount of CO2 as a byproduct.
And that newly generated CO2 diffuses rapidly across the blood-brain barrier into the cerebral fluid.
Exactly. However, the bicarbonate you infused is left behind in the bloodstream.
So the blood pH looks fantastic on your next lab draw, but the patient's brain is suddenly flooded with CO2, creating a paradoxical central nervous system acidosis.
You've essentially weaponized their own chemistry against their brain.
That is horrifying.
And furthermore, once insulin therapy allows the body to clear the original keto acids, all that extra IV bicarbonate you administered induces a severe rebound alkalosis.
Wow, so that's why modern protocols strictly withhold IV bicarbonate unless the pH drops to life-threatening levels, usually below like 6.9 or 7.0.
Exactly. And this really underscores why the Henderson-Hasselbalch equation, which forms the foundation of Rome, isn't universally accepted as the only way to understand acid-base physiology.
Right, because in 1981, Canadian physiologist Peter Stewart introduced a competing framework known as the strong ion approach.
Yes. Stewart argued that treating bicarbonate as an independent variable, like something the kidneys just casually adjust, was mathematically flawed.
So he posited that pH and bicarbonate are actually dependent variables.
Right. They are the forced result of three other independent factors: the total weak acid concentration, the PaSO2, and the strong ion difference.
The strong ion difference, which is the net balance of fully dissociated ions like sodium, chloride, and potassium.
Yes. And while Rome is sufficient for standard clinical care, Stewart's strong ion model elegantly explains phenomena that Rome completely fails to account for.
The classic example being fluid resuscitation.
Right. If you infuse a patient with massive volumes of normal saline, which is just more 0.9% sodium chloride, they predictably develop hyperchloremic acidosis.
But normal saline doesn't contain any hydrogen ions. It's essentially just sterile salt water. Under the traditional Rome model, adding salt water shouldn't cause an acid shift.
Exactly, but Stewart's model explains the mechanism perfectly.
How so?
Well, think of the blood plasma like a crowded dance floor with a strict capacity. Normal saline has a chloride concentration significantly higher than normal human plasma.
Right, it's disproportionately high in chloride.
So when you flood the plasma with all that extra negatively charged chloride, you alter the overall electrical environment, the strong ion difference.
And to maintain electrical neutrality in that crowded room, the body forces water molecules to dissociate, leaving more free hydrogen ions wandering around.
Yes. The chloride influx chemically forces the pH into acidosis without a single drop of actual acid being added to the bag.
That is mind-blowing. So to catch these blind spots in complex ICU cases, clinicians must layer mathematical tools on top of Rome, like calculating the anion gap.
Right, which relies on the law of electroneutrality. The positive electrical charges in your blood, primarily sodium, must balance the negative charges, which are mostly chloride and bicarbonate.
But when you subtract the negative from the positive, there is always a small gap of about 8 to 12 mil equivalents, right?
Exactly. Those are the unmeasured anions, proteins and phosphates just hanging out.
So if that gap suddenly widens to like 25 or 30, it tells you a rogue unmeasured acid has invaded the bloodstream and is taking up negative charge space.
Yes, and clinicians use the mnemonic muddy piles to hunt down those hidden culprits. Things like methanol ingestion, uremia from kidney failure, DKA, or lactic acid from severe sepsis.
And once they find the cause, they use Winter's formula to predict the exact CO2 level the patient should have for a given metabolic acidosis.
It's a mathematical check to ensure the lungs are compensating appropriately.
Because if the patient's actual CO2 is higher than Winter's formula predicts, it means their lungs are failing and they might need to be intubated.
It is a profound shift from simple pattern matching to rigorously confirming the physiological math.
It really is. And this intense multi-layered regulation makes the current pop culture obsession with alkaline diets and alkaline water so scientifically frustrating.
Oh, don't even get me started. The marketing promises that drinking high pH water will alkalize your blood, theoretically preventing disease.
Right, but the premise reveals a total misunderstanding of the physiological defenses we just outlined.
Completely. Your body fiercely guards that 7.40 set point. Between hemoglobin acting as an instantaneous chemical sponge, the lungs adjusting ventilation minute by minute, and the kidneys fine-tuning excretion, dietary intake is just irrelevant to systemic blood pH.
I mean, chugging alkaline water will absolutely change the pH of your urine.
Sure, but urine is the body's chemical trash can. It's a completely different compartment where the kidneys dump excess ions to ensure the blood remains pristine.
So altering your urine pH is not alkalizing your blood.
No, it's not. If your lungs and kidneys are healthy, you couldn't fundamentally change your blood pH with diet if you tried.
So the clinical reality always comes back to respecting the speed of those organ systems. trusting hemoglobin as the frontline buffer, and understanding that compensation blunts a crisis, but it doesn't cure it.
Perfectly summarized.
We spend so much time in medicine viewing acidosis as the ultimate villain, right? Like an imbalance that must be aggressively corrected.
We do, yeah.
But there is a physiological phenomenon that flips that entirely on its head, proving that sometimes the imbalance is exactly what saves you.
Ah, you're talking about the Bohr effect.
Yes,
Yes.
Bohr effect. It is one of the most elegant evolutionary adaptations in human biology.
It really is amazing.
Let's break it down for the listener. When your body is under severe metabolic stress, say you are fighting a systemic infection, or you're deep into a marathon, your peripheral tissues are starving for oxygen.
Right. And they begin generating high amounts of acid as a metabolic byproduct.
Traditionally, we view that accumulating acid as a threat.
However, that localized acidic environment triggers a structural change in the hemoglobin molecules passing through those tissues.
Okay, what kind of change?
The acidosis actually shifts the oxygen-hemoglobin dissociation curve to the right.
So in simple terms, the acid weakens hemoglobin's chemical grip on oxygen.
Exactly. It forces the hemoglobin to dump its oxygen payload much more readily than it would in a normal 7.4 pH environment.
Wait, really? So the very acid signaling that your tissues are in metabolic distress is the exact trigger that forces your blood to deliver more life-saving oxygen precisely where it is needed most.
Yes, it's a genuinely elegant evolutionary trick.
That redefines how we view that physiological tightrope. A slight shift toward acidosis isn't always a failure of the system. I mean, in the most critical moments, that imbalance is the lifeline keeping the entire system intact.
It's an incredible paradox. Sometimes the imbalance is the cure.
What a mind-bending physiological twist to end on. Thanks for taking this deep dive with us. We'll catch you next time.